There is exactly one woman for whom inducing or waiting is a real choice. And by the time you reach this decision, you already know who she is. She is at term. The baby is head down. The fluid is clear. She is well, and her Group B strep swab is negative. Everything that would take the choice out of her hands, a positive strep result, meconium, bleeding, a fever, a head still high and floating, a baby lying the wrong way, a scar on the uterus, is a branch you named before you ever started the induction clock. Those were the earlier lectures. What is left now for the woman with none of those findings is two genuinely safe paths, and the whole of this final conversation is learning to lay them down side by side, honestly, so that she can choose between them.
Start with what inducing her actually buys, because it is real and it is worth saying plainly. Bringing the birth forward roughly halves her chance of infection inside the womb, and it lowers the baby's risk of early sepsis by about a quarter, and it does both without making a cesarean any more likely. In numbers, maternal infection falls with a risk ratio of about 0.49. Early neonatal sepsis with a risk ratio of 0.73, from around 4 babies in 100 down to around 3. And the cesarean rate sits at a risk ratio of 0.84, which is to say not raised at all. So if induction is safer on every count that the trials measured, why is this a choice and not simply a recommendation? Because those gains, real as they are small in absolute size on an already low baseline. A fall of about 1 baby in 100 for sepsis, a maternal infection risk that was never high to begin with. And the thing induction spends to buy them is her time and the felt experience of having the birth done to her rather than arrived at on its own. A benefit that shifts a 2 to 3% risk is worth offering. It is not on its own worth compelling. And every one of those numbers, remember, compares inducing now with waiting, never with the undisturbed spontaneous labor that a woman whose waters have already broken can no longer have. That is the comparison the whole course has insisted on, and it is the one that keeps this trade honest.
So turn the trade over and look at what waiting buys her, because it is just as real. Waiting buys her a genuine chance at going into labor on her own. Most of these women are contracting by a day, and it buys her staying in control of her own birth, and often staying in her own home. Now, the trial evidence on how women actually felt points the other way. Women assigned to induction reported more positive views of their care than women assigned to wait. That finding is true, and it has to be read exactly, or it will mislead you. Those women were not offered a choice. They were handed one at random. So what the data actually show is that among women who did not get to decide, being induced felt better than being made to wait. They tell you nothing about how a woman who chooses to wait will feel about her wait. And a preference measured without any autonomy cannot be turned around and used to overrule autonomy. When you look instead at recent women who did choose to stay home, their satisfaction is high. And the cost barely tips the scale. Inducing with oxytocin runs a little cheaper than waiting, somewhere between about $30 and a bit over $100, depending on the health system. A gap the economists who measured it judged small enough that the decision should simply follow the woman's informed preference. Which is where two respected models of care read the very same evidence and draw the line in two different places, and both of them are defensible. The midwifery position gives the low-risk strep-negative woman a long window. She may wait up to 96 hours before induction is advised, told plainly that beyond 96 hours, no one has actually measured the risk. And even a strep-positive woman, if she is under 18 hours with no other risk factor, is offered the choice, with oxytocin recommended once she crosses 18 hours. The obstetric position closes that door for the strep-positive woman. Induce promptly, do not delay the antibiotics, and do not offer waiting at all. This is not a quarrel about what the numbers are. Both camps agree on the numbers. It is a quarrel about how to weigh them. And you can descend into exactly why each side is reasonable. The obstetric side is built around the one preventable catastrophe in this entire disease, a newborn with Group B strep. And that catastrophe lands almost entirely on the arms that wait. In the strep-positive women, waiting carried something like a 4-fold higher risk of neonatal infection, inducing trended toward protecting the baby. And the single strep-related newborn death sat in a group that was managed expectantly. To close the choice for the strep-positive woman is to close it around that one death. The midwifery side is standing on different ground because for the strep-negative woman, that catastrophe is simply off the table.
What remains for her is a small, mostly treatable difference in maternal infection, set against her autonomy and her chance at a physiological birth. So the same body of evidence that makes induction close to mandatory in the positive woman genuinely leaves a wide window of choice open in the negative one. Notice how narrow the real disagreement is. Everyone agrees the strep-negative, uncomplicated woman should be offered a choice. The argument is only about the strep-positive woman and about how many hours the negative woman's window should run. A narrow, well-located difference over a values weighting is not a mistake for you to correct. It is what an honest guideline landscape looks like. The question of where she waits runs along the same fault line. For the carefully chosen woman, strep negative, clear fluid, a head that is engaged rather than high and mobile, well able to take her own temperature every few hours and reach a hospital quickly, waiting at home looks safe in the observational data and gives her back her hospital bed and her own surroundings. Step off that narrow selection and it stops being safe. The strep-positive woman, where antibiotic coverage at home is unreliable, the woman who cannot monitor herself, the high, unstable head, where the danger is a cord slipping down ahead of the baby. And here, too, the guidelines genuinely disagree. Home management has been linked to more maternal antibiotic use and to a neonatal infection risk roughly double that of hospital care, which is why some colleges recommend against it outright. While retrospective outpatient series, in strictly selected women, report outcomes no different from staying in. Is home safe then, or not? For the tightly selected strep-negative woman, it appears safe in the cohorts that have looked, and it has never once been tested in a randomized trial. That doubling of neonatal infection does not settle the matter against home, because the women managed at home differ from those kept in their strep status, their monitoring, their antibiotic uptake. The same confounding by indication the course has flagged wherever an observational number does the talking. The contradiction is real, and it is unresolved, and it sits on missing evidence rather than on a fact one side has and the other refuses to see. That missing evidence deserves to be named out loud, because it is the quiet reason the whole divergence persists. Every trial that built this course measured infection, and it measured cesarean. Not one of them used a normal physiological birth as its primary outcome. So the very thing a woman choosing to wait cares about most was never the thing the studies were designed to see. And the harm on the other side of her trade, chorioamnionitis, is defined differently from one trial to the next. One temperature cutoff here, the newer triple I criteria there. So even the risk she is weighing is not measured the same way twice. And the one strategy that might make a long wait genuinely safe, waiting while keeping vaginal examinations to a minimum, since the interval that really drives infection is the time from the first examination to the birth, more than the time from the rupture to the birth, has never been tested prospectively with both a physiological birth and chorioamnionitis as the endpoints. If that sounds like a reason to throw up your hands and stop counseling, it is the opposite. The evidence for the obstetric endpoints, maternal infection, neonatal sepsis, cesarean, is solid and randomized. You can stand on it. What is missing is the evidence on her own endpoint. So you counsel firmly on the harms you can measure and honestly on the birth you cannot. And you never dress up the physiological birth side as though it had been proven either safe or unsafe. And that is the whole course in the end. One discipline wearing 8 different sets of clothes. Before you use any number counted in hours after the waters break, name what it measures. Labor starting, the baby arriving, the strep decision that sits at 18 hours, or the infection climbing in the womb. Before you start the induction clock, label the branch, the positive swab, the meconium, the scar that might override it. Compare inducing now with waiting, never with a birth she can no longer have. And then, once the clocks are red and the branch is cleared, the last act is the simplest and the hardest. You lay the honest trade in front of her. Earlier and safer from infection on one side, more time and her own birth on the other. And you let her choose, holding the decision for her only where a red flag has made it yours.